The urogenital system develops from the intermediate mesenchyme, mesoderm, urogenital ridge. The part of the urogenital ridge giving rise to the urinary system is the nephrogenic cord, and the part giving rise to the genital system is the gonadal ridge. Development of the urinary system. The urinary system is made up of the kidney, urinary bladder, ureters and urethra. 3 sets of successive kidneys develop in human embryos. The first set, Pronephros, is rudimentary and non-functional. The second set, mesonephros, is well developed and functions briefly during the early fetal period. The third set, metanephros, forms the permanent kidneys. Pronephros. These bilateral structures appear early in the 4th week. The pronephros soon degenerate. However, most parts of the pronephric ducts persist and are used by the next set of kidneys. Mesonephros. These large, elongated excretory organs appear late in the 4th week, caudal to the pronephros. The mesonephros are well developed and function as interim kidneys for approximately 4 weeks, until the permanent kidneys develop and function. The mesonephric kidneys consist of glomeruli, 10 to 50 per kidney, and tubules. The mesonephric tubules open into bilateral mesonephric ducts which open into the cloaca. The mesonephros degenerate toward the end of the 1st trimester. Metanephros, which is the primordia of the permanent kidney, begins to develop in the 5th week and become functional approximately 4 weeks later. The permanent kidneys develop from 2 sources: the ureteric bud, metanephric diverticulum, and 2. The metanephrogenic blastema, metanephric mass of mesenchyme. The metanephrogenic blastema is derived from the caudal part of the nephrogenic cord. Collecting duct of the permanent kidney develop from the ureteric bud. As the ureteric bud elongates, it penetrates the metanephrogenic blastema, a metanephric mass of mesenchyme. The bud subsequently dilates, forming the primitive renal pelvis, and splits into the future major calyxes. The stalk of the ureteric bud becomes the ureter. The cranial part of the bud undergoes repetitive branching, forming branches which differentiate into the collecting tubules of the metanephros. The first 4 generations of tubules enlarge and become confluent to form the major calyces, and the second 4 generations coalesce to form the minor calyces. The ureteric bud gives rise to the ureter, renal pelvis, major and minor calyces, and approximately 1 to 3 million collecting tubules. Renal vesicles give rise to S-shaped tubules. Capillaries grow into the pocket at one end of the S-shaped tubules and different into glomerulus. The proximal ends of the metanephric tubules are invaginated by glomeruli. The tubules, together with the glomerulus and its capsule, constitute a nephron. The proximal end of each nephron forms the Bowman's capsule, which is deeply indented by a glomerulus. Continuous lengthening of the excretory tubule results in formation of the proximal convoluted tubule, the loop of Henle, and distal convoluted tubule. Between the 10th and 18th weeks, the number of glomeruli increases gradually, and then increases rapidly until the 32nd week. The increase in kidney size after birth results mainly from the elongation of the proximal convoluted tubules as well as an increase of interstitial tissue. Nephron formation is complete at birth, except in premature infants. Positional changes of kidneys. Initially, the primordial permanent kidneys lie close to each other in the pelvis. As the abdomen and pelvis grow, the kidneys gradually relocate to the abdomen and move farther apart. They attain their adult position by the 9th week when they establish contact with the suprarenal glands. This ascent results mainly from the growth of the embryo's body caudal to the kidneys. Initially, the hilum of each kidney, where blood vessels, the ureter, and nerves enter and leave, face ventrally. However, as the kidneys ascend, they rotate medially almost 90 degrees. By the 9th week, the hilum are directed anteromedially. Eventually, the kidneys become retroperitoneal on the posterior abdominal wall. Functions of the kidney. The definitive kidney becomes functional near the 12th week. The kidney recycles the swallowed amniotic fluid containing urine. The kidneys are not responsible for excretion of waste products in fetal life. The placenta carries out this function. Clinical correlates of the kidney. Wilms tumor. This is a rare childhood kidney cancer, also called nephroblastoma. It usually occurs in children under 5 years and presents as an abdominal mass, sometimes with pain, blood in urine, or high blood pressure. Renal agenesis and dysplasia. In renal agenesis, there is complete absence of one or both kidneys at birth. In renal dysplasia, the kidneys are present but malformed, often small and poorly functioning, sometimes with cysts. Malrotated kidney. This is a congenital condition where the kidney is rotated abnormally during fetal development. It can cause abnormal orientation of the renal hilum and may predispose to urinary tract infections or stones. Ectopic kidney. In ectopic kidney, the kidney is located in the wrong position. For example, pelvis, lower abdomen, or even on the opposite side. It is often asymptomatic but may cause urinary obstruction, infections, or stones. Horseshoe kidney. This is a congenital anomaly where the two kidneys fuse at their lower poles, forming a U-shape. Supernumerary kidney. This is a condition where there is an extra kidney beyond the usual two. It usually has its own capsule and blood supply, distinct from the normal kidney. It is extremely rare, may be associated with hydronephrosis, stones, or infections. Ectopic ureter. In this condition, the ureter does not connect to the bladder in the normal position. It may drain into the urethra, vagina, or reproductive organs. It causes continuous urinary leakage, especially in girls, and recurrent infections. Duplication of the urinary tract. Duplex kidney. This is a congenital condition where one kidney has two ureters instead of one. It may lead to reflux, obstruction, or recurrent UTIs. Polycystic kidney disease, PKD. This is a genetic disorder where multiple fluid-filled cysts develop in the kidneys. Development of the urinary bladder. The urogenital sinus is divided into 3 imaginary parts. 1. A vesical part that forms most of the urinary bladder and is continuous with the allantoi. 2. A pelvic part that becomes the urethra in the neck of the bladder, the prostatic part of the urethra in males, and the entire urethra in females. 3. A phallic part that grows toward the genital tubercle, that is the primordium of the penis or clitoris. The bladder develops mainly from the vesical part of the urogenital sinus, but its trigone is derived from the caudal ends of the mesonephric ducts. The entire epithelium of the bladder is derived from the endoderm of the vesical part of the urogenital sinus. The other layers of its wall develop from adjacent splanchnic mesenchyme. In infants and children, the urinary bladder, even when empty, is in the abdomen. It begins to enter the greater pelvis at approximately 6 years of age, but it does not enter the lesser pelvis and become a pelvic organ until after puberty. The mesonephric ducts in the male becomes the ejaculatory duct. At the end of the 3rd month, epithelium of the prostatic urethra begins to proliferate and form a number of outgrowths that penetrate the surrounding mesenchyme. These buds form the prostrate gland. In females, the cranial part of the urethra gives rise to urethral and paraurethral glands. Clinical correlates of the bladder. Urachal anomalies. The urachus is a fetal tube connecting the bladder to the umbilicus, which normally closes before birth. Urachal anomalies occur when this closure fails, leaving remnants that can cause problems such as patent urachus. In this condition, there is persistent connection between bladder and umbilicus. Urine leaks from the belly button. Urachal cyst. In this condition, there is a fluid-filled cavity along the urachus, which can become infected. Urachal sinus. In this condition, there is a blind tract from umbilicus inward, which may cause discharge or infection. Urachal diverticulum. In this condition, there is blind tract from bladder outward, and this increases the risk of urinary tract infection. Congenital megacystitis, also known as fetal megacystitis, defined as an abnormally enlarged bladder detected before birth on ultrasound. Exstrophy of the bladder. This is a rare congenital defect where the bladder develops outside the abdominal wall. The bladder is exposed and flattened on the abdominal surface. Associated anomalies may include epispadias or cloacal exstrophy. Development of the urethra. The epithelium of most of the male urethra and the entire female urethra is derived from endoderm of the urogenital sinus. In males, the distal part of the urethra in the glands of the penis is derived from ectodermal cells that grows inward from the tip of the glands and joins the rest of the spongy urethra. Consequently, the epithelium of the terminal part of the urethra is derived from the surface ectoderm. The connective tissue and smooth muscle of the urethra in both sexes are derived from splanchnic mesenchyme.
If you found this helpful, make sure to like, share, and subscribe, and I'll see you in the next video.